Recording in progress.
All right, just a quick reminder, I already have it in the chat. Make sure your cameras are on during the live sessions, okay, you guys? I'm giving you guys a couple minutes to get your cameras on. Also, I had met with a couple of your classmates, and I've been working on a little instrument lab to kind of help connect the dots. I did not think that I would be done, but I was able to at least do like a dry run for you guys. So it focuses on differentiating similar like hemostats. I figure that's the first place to start because that's where a lot of confusion does come in, trying to determine how do I tell the difference between a Rochester peon and a Kelly and a Cryle and a mosquito. So I again, this is a work in progress. You guys tell me if it works, if it could do some improvement. I tried to make it so that it kind of takes you through how to think about just looking at the instruments, looking at the tissue, looking at the procedures, looking at the names that are in the procedures, because a lot of these instrument names were made for a particular purpose. Okay, so that is up. The link is there. For those of you that are watching the archive, if you go to the archive once I upload this one, it's gonna have HP5 right underneath, and then you'll see like the instrument identification exercise. It's not required. However, it is something just to have as a resource to help you, to help really guide you on how to look at the instruments, how to differentiate, especially with the Kellys, and then you can take the components from this little exercise and then make it your own. Okay. So the I'm not able to email the link. It is actually, and that's a good question. I'm not able to email the link from here, but the link is already like I've already opened it in Moodle. Sorry, I'm kind of congested, guys. I've already opened it in Moodle. It's already live. So if you were to go into Moodle now, yeah, it's already in Moodle. So if you were able to go to Moodle now, it's already live right under where the archive would be. Of course, the archive's not there yet because we're doing the live session now, but the um instrument identification exercise is live. So check it out. Give me some feedback. Let me know. Granted, it's just a quick little, let's see if this works. If it does, then I can kind of extend it, add, like a clamping instrument. Because right now it's just clamping, but I can add like cutting, depending on if this works. Okay. So someone check it out, let me know, and then we can kind of go from there. Now, if you do complete it, okay, I want you to pay attention to how your thinking changes from the first slide to the last. So it's five, and then the sixth one is like, yeah, you did it, kind of like a little congratulations. But I do want to know because that shift is what really matters, especially when it comes to understanding the instruments, being able to differentiate the instruments, and then it carries over to when you are in the lab and you actually have them in your hands, and then you can literally see, oh, I get it now. Like with the Rochester peon, the fenestrated, or the, I call them just the serrations, they go all the way down to the shaft, versus the Kelly, it's half, versus the Halstead that's a lot smaller but they go all the way down. And so you'll be able to kind of look at it that way. Okay, good. All right. Okay. Now, tonight's a little bit different. We do have a video that we're going to watch because draping is really important. That is one of the things that we do with our surgeons. Sometimes, in some rare cases, depending on your facility, you may drape by yourself. I've had many times where I've had to drape the patient by myself, and then the case would start. But most often, it's you, your surgeon, the resident. There's someone there. Okay. But before we even get into that, we got to talk about getting the patient positioned. There's certain things that we look at, from nerve integrity, skin integrity, circulation, infection risk. I can tell you that the next half of module 3, it does feel a little bit smoother than the first half, because the second half, there's more visualization and it's easier to kind of put things into place versus like sterilization, instrumentation, where it's a little bit hard to kind of connect the dots. But trust the process. We are trying to just fine tune different things to make it better for you. Okay. So, again, just another reminder, make sure your cameras are on. Make sure your cameras are on. All right. So, let's jump in. One of the biggest things to think about is when the patient is anesthetized, they lose ability to sense any type of harm. That means that we become the patient's eyes, the patient's ears, and that proactive system. Remember, we're the advocate. Now, please keep in mind that once anesthesia has been given, the patient cannot shift their weight. They cannot feel pressure, pain. They can't even protect their eyes or their skin. The body's warming system is actually turned off. That doesn't make them weak by any means. It just means that they're more dependent on us. So, this is why we pay especially close attention to the field. When you get, for example, your mail stand, you want to make sure that your mail stand is not pressing down on the patient's legs. Believe it or not, it's easy to kind of be like, oh, I forgot, and just kind of run your hands underneath to make sure there's just enough gap so that that mail stand isn't pressing down on the patient's legs. Now, as CSTs, we are often the person closest to the patient's body throughout the entire procedure because we're right there at the field. So we notice sometimes pressure points. We know that on some cases we have to be careful with resting our elbows or different things on the sterile field, which is the patient. We are very aware of improper alignment, skin contact with equipment, even risks before an injury occurs. We're already thinking about it. Okay. This is what we talk about as or call guardianship. In real surgical cases, patient injuries, they don't usually happen because, oh, that person doesn't know what they're doing. Why are they in here? They happen because, honestly, no one noticed something earlier during the procedure. Now, being the patient sensory system means that we are constantly having on another hat. Remember, I told you guys have lots of hats on. We're scanning, we're checking tubing, we're looking at arms, things that are in vulnerable positions. If there's breaks in prep or draping, we're seeing it. We're looking at environmental hazards that are near the fields. So let's think about this together. If a patient cannot feel pain or discomfort, what type of injuries might they not be able to protect themselves from? They're intubated, they're on the table, and maybe our mail stand was a little too close to their legs and it's been pressing down on them for like 4 or 5 hour case. Leaves a bruise, most definitely. They could be sore, there could be nerve damage. The nerve damage we may not notice, but the patient may complain of pain in an area that there was not even any type of surgical procedure going on at all. They went in for, let's say, facial reconstruction, and now they're complaining that their shin is sore or for whatever reason, right? And maybe there were like 4 or 5 people at the field. So you got your surgeon, first assist, maybe there's 2 interns, and now somebody was laying something down on their shin that was on that shin for 4 or 5 hours, right? Now, again, the patient is trusting us and we're learning how to just kind of be the best patient advocates that we can. Okay. We also talk about why this is important. Like I said, the second half is a lot, it flows a little bit better because we're talking about proper circulation, nerve, tissue integrity. we're trying to maintain the patient's physiological components while they're not able to protect themselves. Now, positioning is not about getting the patient out of the way, okay? It's about defending the body while surgery is happening. When a patient is anesthetized, the body, again, they're not going to be able to complain or even protect themselves. So, positioning becomes a form of psychological support for these patients. Small positioning choices, how we lift, where pressure rests, how limbs are supported. All of this can prevent serious injuries that may not appear until hours or days later. Now, it's going to be important because you're going to be asked this week in the exercises, I think exercise 1, about certain beds. Okay? There is a diagram of the different beds that are in Moodle that tells you the different positions that we put our patients in. When you look at that, I want you to kind of think about where the pressure points are. What would be vulnerable? What other things that you would want to have to protect the patient? For example, when we're doing a rotator cuff, um, a lot of times we'll have the patient on their side using a bean bag, which is just a bag full of beans that we use a suction to harden it and we put the patients on their side. Now, we don't just use that. We have additional pillows, we have additional padding to make sure that we are protecting every bumpy part on the body. This is for both in practice and the exam. Okay, so that was a good question. Now, the good thing in the operating room is the bed is usually, knock on wood, the bed is usually always locked. But we still check it because you never know, especially in between cases. Somebody unlocks it to clean underneath. We just make sure that it's locked. But 9 times out of 10, the bed, luckily, is one that it's a real quick check. Okay, the bed is good. Okay. Now, in the operating room, positioning injuries often come from sliding tissue instead of lifting. Um, Prolonged pressure, like that Mayo stand over the shin, because the bony prominence, bony area, overstretching, or even compressing down on nerves. These injuries, again, they're not going to happen because someone is actually trying to, like, I want to see how long I can put my arm on this person's leg before it turns blue, right? That's not happening. But it's with certain things where that you become complacent and you forget to kind of just swipe your hand under the meal stand really quick, or as you're adjusting it, making sure it doesn't fall down onto the patient's body. When skin layers slide against each other, the tiny blood vessels can actually tear. That's why lifting patients rather than pulling them matters, even when, you know what, time is short and we got to get this next patient in. We're still going to take our time because it's one patient at a time. Okay. Pressure plus time reduces blood flow. Areas like the heel, the sacrum, the back of the head, they're very vulnerable. If tissue doesn't get oxygen, injury, of course, can occur even without visible signs at first. Nerves don't like to be stretched or compressed. So if you hyperextend, right, like hyperextending something past 90 degrees, you can injure it. Pressure from stirrups. So in OBGYN, we place the female patients in stirrups. We move the legs at the same time. We're trying to prevent peroneal nerve injury, okay, which is extremely important. Now, these injuries can lead to numbness, weakness, or even long term deficits. So, if a case is expected to last several hours, let's say me and Emily are scheduled for a spinal tethering. Those cases can last anywhere from 12, 16, 18 hours, depending on how bad um, the spinal cord is. Okay, because they're trying to separate the tether. Okay. If the patient was in a bad position, I want you to think about the risks that increase with time. We're not talking about like a 2 or 3 hour case. We're talking about an extended 12, 14, 16, 18-hour case. Um, think about what could happen to that patient. Definitely swelling. When we position with intention, we protect nerves, we protect circulation, and really the dignity of our patients, even when that patient can't speak for themselves. Now, we look at gravity as the enemy. Okay. Gravity affects circulation, respiration, and patient stability during surgery. When a patient's position changes, their physiologically, I think I said that wrong. It also changes with it. Okay. Now, I got a message about the legend on the position study guide on Moodle. And this is perfect to tie in with this slide. So thank you for bringing that up. When you look at that legend, let me see if I can pull it up really quick, y'all. Give me a second so that you guys feel comfortable as you're reading it. Okay, let me pull this over. We go down. Okay. So when we look at this kind of tells you that in every single one of these positions, there are pressure injuries. I want you to look and see where would those pressure injuries be. There's nerve injuries. Okay. And as you can see, every single one of these positions, there is a potential for pressure, nerve, or even circulatory respiratory risks, especially when we get into, like, let's say the Wilson spine or even the knee chest, the fracture table. Think about that one. Okay. Jackknife, Trendelenburg, or even reverse Trendelenburg. It comes with different potential problems. Okay. And I feel like I'm gonna have to update this one because reverse and Wilson frame are incorrect. So be on the lookout because I will be fixing those two because I want you guys to get those correct on the this week's exam. Okay. But that's the whole point, to kind of look and see where would the pressure points be. Okay. Now, in Trendelenburg, the abdominal contents shift towards the head. Okay. When we look at why different things are important, why certain positions are done versus others, we look at how to prevent complications before they start, especially in those longer cases. For example, the lungs can be compressed, abdominal contents are being shifted, we have increased pressure on nerves, blood vessels, and it causes patients to slide if they're not properly secured. This effect could be gradual, but they're very real and they are preventable. Okay. When the patient is tilted head down, the abdominal organs are going to come towards the chest. So we look at, you know, the reverse, what's happening. And when the patient's head's down, when they're head down, what are some things that could be, okay, let me change that. Would it be more difficult or easier for the patient to breathe if they are head down, meaning they're on their back? Or would it be easier? Right, it's difficult. Even with being intubated, right? This is why communication with anesthesia and there's careful monitoring. That's why it is so important. Okay. Now, once gravity starts pulling, we ask, what's stopping the patient from sliding? Shoulder braces sometimes we'll put in that are helpful, but we have to make sure that we're careful with the brachial plexus so that that doesn't get injured. We rely on bean bags, non slip pads, and really just a lot of thoughtful support. When we have reverse Trendelenburg, gravity works the opposite direction. The footboards and their securing positions are so important because we're trying to prevent shear injuries. Does that make sense before we move on? Okay. Like I said, this one's a little bit, it starts to get easier. I promise. I promise. I promise. Okay. Now, positioning errors often come from misunderstanding. So that's why we go into the why behind positioning rules because we're trying to prevent injuries. Most positioning mistakes happen because the rule wasn't fully understood. Like someone is really gung ho and they want to help, lift the legs for a GYN case and they maybe go too fast because we literally go at the same time. One person's on one leg, one person's on the other, and we go at the same time to prevent injury. Now, here we go. All right, here's an example. We're going to look at female catheterization. That requires the patient to be in frog leg positioning. So, not just legs apart, we actually put them in a frog at the same time. So, their safety straps, they have to be placed about 2 inches above the knee, not directly over a joint, right? Because we don't want to injure the joint. Arm boards, they're never going to be extended past 90 degrees, okay? Because exceeding that angle increases the risk of that brachial plexus injury, and that's something that we do not want to happen. The rule exists to protect nerves, okay? So if we're in a case and someone suggests a shortcut in positioning, how might you explain your concern using safety instead of authority? It could be a brand new intern. It happens. How are you going to explain to them? Wait, we can't do this because you may be in that position sooner rather than later, believe it or not. As you guys are thinking about that, we get into layer two. Now, in the operating room, things are happening simultaneously. So it's not like one person's waiting for another to do something. And you'll figure this out once you guys get into the lab. You're doing things at the same time, okay? But the skin prep is just about reducing risk. Remember, we cannot sterilize skin. So we're just trying to reduce the amount of microbial microbes on the skin, okay? I say that because you may see concepts. So, just a reminder, skin can never be sterile. Skin can never be sterile. Okay? So that means our goal is again trying to reduce microbial load. So we kind of go back to a little bit of micro. Okay? Okay, so why does this matter? When you kind of understand the prep, you're watching, depending on your facility. Not all techs prep, but it's important to know when the prep has been contaminated. So you're looking for thoroughness, consistent, intentional. And a lot of times there's a lot of pressure going on. This is when we're trying to get rid of that um, transient flora that poses higher risk, especially if we're doing a big belly case. So we're going in deeper tissue. That prep creates a defensive zone that lowers the chance of our patient getting an SSI. Okay. Okay. Now, scrubbing isn't just busy work. We're actually trying to use friction to remove dirt, oils, microorganisms from the actual skin. Okay. Why do you think we prep a wide area, much larger than the planned incision? Because I have seen concepts like this on as well. The incision's this big. But our prep is going to go way beyond. Think about anticipation. Let's say we're doing a laparoscopic appendectomy, we get a bleeder. Now we have to cut them open. It's rare, but it does happen. So now that I've put it into that context, why is the prep area much larger than the planned incision? What would happen if we only stayed in the parameters of a laparoscopic case? So the incision ports are small, and we didn't even prep the entire abdominal area. Would, and then all of a sudden we have to go open, okay? Is it possible that there are going to be areas that have not been cleaned? Yes, in case we have to open. So we don't want to risk an SSI. We don't want to risk a patient potentially getting an infection. So we always prep more than less. Okay. We're going to show you how to prep in the lab. You always start at the incision site, cleanest, and work outward peripherally. Okay. Also, the incision is the cleanest area. That's because it's where we focus the most attention. If you see a concept that's asking, where would you start your prep? And they don't say incision site, maybe they say the cleanest part of the body or something crazy. Just know that the incision site is considered the cleanest part. Okay? As we move away from that incision site, the skin becomes progressively less clean. The spiral pattern isn't tradition, it's what we do as strategy. It keeps contaminants moving away from the incision, not towards it. Okay. So we're always at the incision going outwards. Now, if you bring a sponge back towards the center, you've actually unintentionally transported all those little microbes from the dirtier skin into the cleanest zone. That's where the incision will be made. Okay. Right. Then it becomes contaminated. Other things that we look for. Okay. You may be set up and you may even break scrub. It'll make sense once you get in lab, but you may break scrub and be asked to help move a patient, do different things. When the prep is done, they're always checking for pooling. Pooling is any fluid that has accumulated and not been dried from the prep. Okay. Fluids don't always stay where we put them. So during the prep, it actually can run down the sides and it can actually soak areas we are like watching closely. So when fluids sit, pressure and time passes, depending on what that fluid is, it can actually irritate and burn the skin even without heat. So we show you how to properly dry the patient. It's a whole formula so that we do not contaminate. Okay. Now, with that, there's boundaries. So we still want to have big areas, but we shift from where do I prep to why prep this much. The boundaries are where we look at the surgeon's first moves. They are preparing for what might be needed next. When we prep with intention, we're protecting sterility even if the procedure changes. So we don't have to worry like, oh no, we're going from a laparoscopic case to an open case. Did we prep enough? We don't have to worry because especially for abdominal cases, we're going to prep from nipple line to peritoneum and sometimes down the thighs, depending on the surgeon's preference and how, that facility does them. We prep large areas. If the prep's too small, the team is forced to choose between, okay, we got to break sterility or limit care. Oftentimes during these cases, it's an emergency. So you don't want to stop to be like, okay, we got to break down really quick, reprep, and then redo it. Or in some cases, they're splashing. A lot of times in a C-section, emergency C-sections, they're going to splash and go. What I mean by splash and go is they'll take the surgical prep and literally splash the patient with it, because in that time it's life, right? We're trying to save the life. But the anticipation keeps the patient protected and it keeps everyone flexible. In real cases, plans change. Okay. A vein may be unsuitable. A drain may now be required. So it's not going to be necessarily in the incision site, it may be next to it. Access may need to be expanded. In the case where we were laparoscopic, now we're going open. So here's a scenario. Okay. The requirement is a full leg prep, circumferentially and often bilaterally. But why? That's because the surgeon may need to access an entire vein or pathway. A lot of times in heart or cardio, they're going to prep the heart, but they're going to prep a leg as well. Okay. And they do both because they may have to switch legs if the vein from the one leg is just not suitable or usable. So prepping only a small area limits options, and then it increased risks because now the drapes are down. What do we do? Right? Now, this prep here extends from the chin and it goes past the umbilicus, right? We're looking at a radical mastectomy. And it's also prepped laterally from the thorax to the table surface because sometimes they have to get to lymph nodes, and do extensive tissue manipulation. And a lot of times the drain may be nowhere near or closer, away from the site. So they want to have space, okay, for the just in cases. Does that make sense? Because I have seen concepts on that. Okay. Another thing, we look at draping and we have a video that we're going to watch. But draping creates the boundary between sterile and non sterile areas. Once the boundary is set, it has to be protected to maintain patient safety. I want you to think of drapes as more than just the fabric that goes on. Once a drape is placed, they define the rules of the environment. Everything inside the field is considered safe. Everything outside is not. Draping doesn't just cover the patient, it establishes that sterile workplace where surgery can actually happen pretty safe. In real cases, contamination often occurs after draping. Drapes are shifted, they're adjusted, or even repositioned. When a drape is moved, I want you to think particles from the non prep skin or even the environment can be pulled near or into the sterile field. That's why when we drape, we place it and we walk away. We don't adjust. Okay? We're just trying to prevent microscopic contamination, and you'll see that in the video. Now, when we're placing the drapes, we use a technique often called cuffing. When you watch the video, I want you to notice they're cuffing, okay? I'll also be sending you guys one of the videos that me and one of my coworkers made where we kind of show you. When we cuff, we're protecting our sterile gloves. We keeping the sterile surface of the drape sterile. We're keeping the field integrity intact, okay? Now let's think about this together. If a drape looks slightly off after placement, what risk comes with trying to adjust it even a little bit? I've got one for, yes, exactly. Your sterile field can become contaminated. Now, when you guys get into the lab, you'll be able to identify the contamination, but it's going to be just as important to know how to fix the contamination, okay? And you will learn that. Other considerations to think about. Sometimes we have lasers. Um, Standard draping alone is not enough, so we have certain drapes for that. Laser specific um, strategies that we use. In most case, standard drapes will protect the sterile field. But when laser comes into the room, we're talking about high heat. We're talking about already being in an oxygen rich operating room. Materials that are normally safe become fuel. So we have other precautions that we put into place. Laser cases are one of those times where we may have we usually have wet towels in a single basin in our field or like near our field just in case. Not because we're like expecting the laser to blow up the place, but we just want to make sure that we are being prepared for any potential risk that could happen. Okay. We get to the gravity rule. Sterility has a physical boundary. Anything below the table is considered non sterile and cannot be brought back into the sterile field. Now, hear me. When you get into your clinicals, just remember, per the book, you do not want to grab anything under your sterile table. Okay? I want you to think of gravity as that final decision maker in sterility. Once something drops below table level, gravity has pulled it into the non sterile zone. Even if it looks clean, we treat it as contaminated. Okay? And that's because we can't control what it contacted on the way down. Okay? That is really important. In real cases, the drapes may slide. Gowns may brush up against the table edge that wasn't sterile. Instruments or tubing may drop slightly. If it drops, let it drop. Okay? You don't want to contaminate trying to grab it really quick because the risk is just too high. So, we get into this video that I mentioned. Okay? Now keep in mind, draping is where now we're making the sterile technique becomes a physical technique. Now, this video is going to help you to observe how we plan it, some restraints. Now, she is going to do 2 different beginning drapes, okay? There's 2 options. We don't do both. So she's going to show how to hand 4 towels, and then she's going to show how to hand 4 disposable sticky drapes. But I want you to know we don't do both, we do one or the other. And she's showing both because some surgeons prefer towels and some surgeons do prefer the sticky tapes. Okay? Some facilities, they prefer a down drape first. Some facilities prefer the 4 towels first and vice versa. So that's just technique or preference. The key is to not contaminate and just follow the flow of how your surgeons, how they go. Okay? So let's watch the video.
Hi, okay, this competency is after you gown and glove your surgeon, which is Candace here. We are going to move on to draping. So we're going to drape as if this is an appendectomy with a laparotomy drape. I'm starting with the squaring off. What you see here is the 4 towels. There's going to be 2 different ways to do this. With 4 towels, I'm going to hand off one at a time. See that how I'm holding all 4, but I'm handing one at a time. Now I get the other one ready. While Candace puts that on, and we do the same thing for all 4. And then, I don't know, do you want to keep going through? Mm-hmm. Okay. Okay, now what you're going to see often, Matt, come on over here. What you're going to see often is the paper disposable drapes. So you'll have 4 stickies. The best way to do this is one at a time. I'm going to take one sticky and remove and hand. While the surgeon's doing that, now I'm going to get the other one ready. Keep going, just one at a time so they don't all get stuck together. Okay, last one. We're then going to move to our 3/4 sheet, and this will be used as a down sheet. I grabbed it like a book. This is the folded end here. I have the open end, that's in my right hand. I'm gonna open this up to the center. So there's a lot of areas that you can open this, but you need to go right to the center where we have these two ends here. I'm gonna hand one end to Candace. We cannot come too low. I don't wanna contaminate. And then I'm gonna take the other end on my side. See how we're still hovering above. We're gonna pull one end out, and like at Candace's nice cuff there, you're gonna make that cuff every time you're putting a drape down. Big important thing, do not follow this drape down. See how low I am? When we came here, we let it go. Okay, you don't wanna drop too low. Now we go to our lap sheet. You see the adhesive here. I'm gonna ask my surgeon, would you like me to remove the stickies or keep it on? Remove the stickies. So I'm gonna take that off. That's garbage. I'm making a pile of garbage here. I'm holding it again in that same book position with the fold or the spine of the book that's gonna go on to the patient. You can see there's always gonna be a picture that tells you which way is the head and which way is the foot. Can you see that, man?
Yeah.
Okay. So now I rest it over our incision. The surgeon's gonna take their half. Again, we wanna make sure that we're not coming in the wrong spot. We wanna come in the center there. You can see the two arrows. Now we're doing that same movement, pulling them away from the patient. Where am I? We going up or down first? Down. Okay, down. Now bring it all the way down and drop. Come up here. When you go to put up, I want to make sure that you have a cuff here. Okay? Your hand has to be within that cuff. The reason for that is anesthesia is behind there and is going to grab that drape from you, and you don't want your hand exposed for them to grab. So we're considering that whole area unsterile. We're staying inside. Okay? We're going to drop it now because we don't have anesthesia. Okay, at this point, the surgeon is...
All right. So we use that same video further on. I think next week they show us more. But the biggest things is we go with the surgeon. So if the surgeon starts first top, we do top. The surgeon goes down low first, we do low. We just follow their lead. Okay? Does that make sense? Because that's going to be something that you're going to be doing pretty much almost every case. Okay, perfect. All right. Now, awareness happens before harm. Advocacy happens before injury. This is where we kind of recognize those moments and we try to trust our role. Okay? What do I mean by that? We're going to be the first person to notice subtle changes. Pressure point developing, fluid being pulled from a prep, drape edge slipping. We're going to see it. Trust me, you're going to be able to multitask like you've never multitasked before. You're going to be seeing a break in sterility forming before it even happens. And you're going to be like, hey, doc, hold up. Or, doc, I just noticed that your glove is ripped. I got another one already ready for you. Let's go. Okay? When you catch it early, you prevent the problems later. When fixing them is harder and riskier, right? Like you notice it early, like let's say the case just started and you see a tear, you already had the surgeon's gloves up. It was just a bada boom, bada bing. Circulator took the glove off, you popped a new one on for them. Again, remember, our patients are asleep, so they're not going to be able to let us know, I feel pain, this is not comfortable, or I sense danger. Now, we also have robotic procedures. Complex procedures that require a little more layered thinking. Okay? Safe outcome depends on anticipating how positioning, gravity, and equipment affect, again, the patient over time. So you have some kind of prompts over here. When we look at gravity, we're talking about the head, the neck, congestion. Respiratory, okay? We're looking at the viscera. We look at what stops the slide. We'll have a gel pad here. We'll have some shoulder braces just to keep the patient from sliding off the table, which means our draping is going to be customized for this particular procedure with this particular robot. And here we're talking about a prostatectomy. Okay. And you see, we're already in Trendelenburg. Okay. Now, in steep Trendelenburg, we look at the blood volume shift. That's going to be one of the things we're looking at. When the patient's head is down, think about what's pushing up against the diaphragm and vice versa. So, any of those positions that you saw, think about how the body is going to react. Okay. Where's the tubing going to go? When we are doing a cervical spine case and the patient's prone, right, head down, think about how anesthesia has to be very careful to monitor their oxygen levels, right? A lot of times we have a mirror on the bottom for them, but it's still going to be risky because we have to make sure that we don't have too much pressure on their lungs, on their diaphragm, because remember, they're prone, okay? We look at the robotic arms themselves, how they move, how they pivot, how they hover over the field, and how we drape the robot to maintain sterility without restricting movement. I'm going to try to find the video of draping the robot because you're draping every single arm, every single piece. And you just want to make sure that you don't break sterility while you do it. Okay. Now, patient safety is going to be built before that first incision is made. First and foremost, we're draping because we're trying to protect layers that prevent harm long before performance, before the knife goes onto that patient's skin. Everything we talked about, positioning, prepping, draping, this happens before surgery even begins, before the surgeon is handed that knife. Protection always comes before performance when you think about it in the operating room. Okay. Um, we think about nerve, skeletal bones we're trying to protect. We're thinking about skin, tissue integrity. We are looking at the sterile field and reducing any potential for a surgical site infection to occur. For those of you that are watching the archive, I want you to explain the risks of a urinary catheterization. Explain the rationale of why we even do the surgical prep and what techniques are used to prevent contamination of the gloved hand while draping the patient. Also, remember that while we're here, the HP5 instrument guide, granted, you guys are my trial run. I just wanted to try to see if this will actually help. Let me pull it back up since I'm already over here. So for those of you who weren't here earlier, I want you guys to be able to have that same information. So underneath, now keep in mind, this is instructor mode, so the live archive is not up yet. You will see. But right here, okay? Let me send the link again. Copy the link for you guys. This is to help with instrument identification. Okay, I just chose clamping instruments this time, and I'm just going to be looking for your feedback to see if this works. If it does work, I can try to, add a couple different things for it or sprinkle some type of instrumentation each week up until finals. But I want your feedback to see if this is something that will actually help. Okay. Now, keep in mind, it's just to kind of guide you as you guys are trying to understand. You see, I'm not saying memorize, but understand how and why and what tissues certain instruments are used on and in certain services. So I start off really simple with just the clamps today. The two that usually get the most confused, actually the four that usually get most confused. And once you go through, you'll kind of see it's not a requirement at all. It's just another resource that I'm trying to see if it works. And if you guys do like it, I will try to sprinkle, maybe next week we'll do retractors and, something so that you'll be able to feel more comfortable with instrumentation for that cumulative final. Okay. But again, I do want feedback. Okay. Because that's the only way I'll be able to help you guys a little bit more for, as we get closer to the cumulative exam. Okay. With that, what questions do you have for me? None? Okay. With that, you guys, please have a wonderful rest of your evening. Be safe this weekend. And I look forward to seeing everyone who can attend next week, which is week 7, which is crazy already, live session. Good night, everybody.